Hello, I'm Marco Davis, President and CEO of the Congressional Hispanic Caucus Institute. Welcome to CHCI's 2023 Capitol Hill Briefing Series. This series is the culmination of CHCI's premier 9-month postgraduate fellowship program, which offers exceptional Latinos from throughout the country unparalleled hands-on experience working in public policy here in Washington, D.C. This unique fellowship program seeks to enhance participants' leadership abilities, strengthen their professional skills, and increase the presence of Latinos in public policy areas, this year specifically in the areas of health, technology, housing, education, and the environment. CHCI is thrilled to offer our postgraduate fellows the opportunity to share their perspectives on policy issues they're passionate about and convene leaders in this work for an informative conversation. We'd like to thank our postgraduate fellowship program sponsors, whose support for the program is invaluable. The sponsors include Meta, the PepsiCo Foundation, America's Health Insurance Plans, the Walton Family Foundation, Bristol Myers Squibb, Microsoft, DaVita, Wells Fargo, and CVS Health. During and after today's session, you can keep this important conversation going and broaden the number of people engaged by using the hashtag CHCI Fellows on social media. We hope that you will. To learn more about our postgraduate fellowship program, as well as our other leadership programs and special events, please visit chci.org. And we encourage you to reach out to our fellows directly via LinkedIn to learn more about their policy topic, and also please help them connect with job opportunities for when their program concludes in May. Thanks so much for joining us. And now, enjoy the discussion.
Hi, I'm Senator Martin Heinrich. It's an honor to welcome you to this briefing hosted by Cristo Luna, a Congressional Hispanic Caucus Institute Fellow in my office, this year working on health policy. Cristo has been a real asset for my team. He has brought a valuable on-the-ground perspective on healthcare issues based on his work in an emergency department in New Mexico. I would like to start just by saying how grateful I am for the work that the Congressional Hispanic Caucus Institute does to develop the next generation of Hispanic leaders and policymakers. Over the years, I've had a number of fellows, interns, and staff members in my office benefit from CHCI's resources and programming. Today's briefing will touch on a pressing issue for the folks in my home state. I believe that healthcare is a human right, but for many years, New Mexico has faced a severe shortage of medical providers. The pandemic only worsened our need for a quality healthcare workforce. New Mexicans living in rural communities also face long drives to their medical appointments. A lack of access to high-speed internet limits access to telehealth services. Access to healthcare should not depend on where a person lives or, frankly, what a person can afford. Our friends and neighbors should not have to choose between putting food on their table and going to their doctor's appointments. During my time in Congress, I've been proud to vote for key reforms in the Affordable Care Act, the American Rescue Plan, and the Inflation Reduction Act to expand access to affordable and high-quality health care. But there is so much more left to do. I hope that this briefing, which includes the healthcare legislative aide in my office, Claire Wengrod, provides space for a productive dialogue on these key challenges. Please work with my office to advance solutions that will improve healthcare delivery, address our healthcare workforce challenges, and make sure every American can access the care that they need. Thank you.
Hello, everyone. Thank you, Senator Heinrich, for your opening remarks and your commitment to serving New Mexicans and people of the United States. What an honor it has been to have my placement in your office. I'm sad that It is coming down to my last couple of months. As a New Mexican, it has been an honor, to serve in a New Mexican office. A little biased, but I could confidently say I've grown professionally, and I will always have this experience throughout my life. So thank you. And jumping right in, hello everyone. My name is Cristo Luna, and I am the American Health Insurance Plan's AHIP Health Graduate Fellow in the office of Senator Heinrich. I'm originally from Las Cruces, New Mexico, and I have a strong background in healthcare. I started my healthcare career during the midst of the COVID-19 pandemic in January of 2020. I was a care coordinator in the emergency department in one of the largest hospitals in the Southwest. Serving the local community in the ED was a humbling and eye opening experience. I was able to see firsthand some of the issues Latinos and other underserved communities face in health, such as health literacy, inequities in government legislation, and access to community resources, which ultimately leads to poorer health outcomes. And we will be discussing some of those issues today with our panel. It is my pleasure to introduce some very accomplished professionals to our discussion today. Our first panelist, her name is Claire Wengrod. Claire is currently a legislative aide for the office of Senator Martin Heinrich, where she serves as the senator's advisors on all things related to healthcare, IHS Veterans Affairs, postal issues, women's issues, and senior issues. I've had the pleasure of working with Claire on health-related issues since the start of my fellowship. I've been able to learn from her on the job in the Senate, and thank you for always giving me advice and constructive feedback throughout my fellowship. Thank you so much for being here. And now, without further ado, some remarks from Claire.
Thanks so much, Cristo, and thank you so much to CHCI for having me today. I'm really excited to talk about the challenges that people face when seeking healthcare, and particularly the challenges that New Mexicans face when accessing healthcare, and often how the emergency room is the only place that they can get care. So I'm really excited to hear from the fellow panelists and share my perspective from a federal standpoint as to what policymakers can do to improve access to healthcare and what the role that care coordinators play in moving the needle in this issue. Thanks so much, Cristo. I'll pass it back to you.
Great. Thank you, Claire. And for our second panelist, Michelle Jester. She's the Executive Director of Social Determinants of Health at American Health Insurance Plans, AHIP. At AHIP, Michelle helped health insurance providers address socioeconomic barriers to good health by bringing innovative interventions to scale, highlighting sustainable community collaboration models, and leveraging policy solutions that help advance equity. My official title is the AHIP Health Insurance Plan Graduate Fellow. So thank you so much to AHIP and to people like Michelle for always sponsoring us fellows throughout the years. I'm looking forward to hearing more about what AHIP does, and thank you for being here. And without further ado, I'll turn it over to Michelle for her opening remarks.
Thanks so much, Cristo, and hi everyone. So wonderful to be here with all of you, and we're honored to be able to support fellows like yourself, Cristo. It's such a great experience, and we need more people like you gaining this invaluable experience and bringing it back to your community. So I'm very excited to be a part of it. So as Cristo said, I'm the Executive Director of Social Determinants of Health at AHIP. I'm really looking for payer solutions and community collaboration models to help sustain and scale social determinant solutions that help really facilitate access to care. Prior to joining AHIP, I worked with federally qualified health centers for 10 years. And for those who aren't familiar with FQHCs or community health centers, they are community owned and community driven primary care organizations that offer comprehensive care to anyone, regardless of their ability to pay. So I think they're a great part of the solution when talking about access to care. And then just a tiny bit about my background. I have a community-based participatory research background or a community-engaged research background. And so in all of the work that I do, I'm very much trying to be rooted in the different communities, listening to them, understanding what their priorities are, what their strengths are, what their values are, and then working with them to tailor solutions and come up with culturally appropriate solutions. So that's the I think the ethos that I try to take through all of my work. So I'm looking forward to the panel discussion today. Thanks again.
Thank you so much, Michelle. I really appreciate it. And for our last panelist, Bernie Living. Bernie is a public health social worker, currently working as a consultant and contractor for a statewide overdose prevention education coordinator on New Mexico's various health grants with the Behavioral Health Sciences Division, Office of Substance and Abuse Prevention. I had the pleasure of meeting Bernie during a healthcare team meeting with Senator Heinrich's office. I was very impressed by his background and the work that he does on the ground and in the community. I'm excited to hear more about what he does, and thank you so much for being here, Bernie. Your background's so impressive, and we're looking forward to hearing from you.
Thanks very much, Cristo.
Yes. Did you have any opening remarks for the panel?
Just a quick sort of personal anecdote. In the last year, for the first time in my 60 years, I have had to be engaged with the healthcare system. I had a osteoporotic femur fracture last May, and for the first time in my life, have had to deal with insurance companies and prior authorizations and all the things that I have worked with community members on over the last 20 years as a social worker in New Mexico. And well-sourced and literate patient have found how difficult it is to navigate the healthcare system and to get the care and medications that I need. So I have finally been able to sort of mold together my professional background with personal experience to engage providers in the community to ensure that people who are not as well sourced as I am are getting the care and engagement they need, both at primary care and behavioral health level. So again, thanks for having me. It's an honor to be here, and hello to Senator Heinrich. Good to see him this morning.
Oh, thank you, Bernie. Yes, those personal experiences really, shape what we do in our work every day. And, I think it's even better if we have experience, so we could translate into the people that we help every day. So thank you so much, Bernie. At this point of the program, we'll begin the Q&A session. I will start off by asking the first couple of questions to our panel. Please feel free to engage with the panelists throughout the time. And when you enter your question in the chat box, please specify what panelists you would like to answer it. Alrighty, so to start off, we will start with Claire. From your experiences back home in New Mexico and in DC, from a government lens, what are the biggest health barriers that we should be focused on that are affecting the Latino and the Hispanic communities?
Yeah, thanks so much, Cristo, for this question. I think there's a couple of really big barriers that, from a policy perspective, we should be focused on to help Latino and Hispanic communities in accessing healthcare. The first one that comes to mind is language access, ensuring that Latinos are able to access healthcare in Spanish, if that's their first language, is really important. And the senator actually introduced a piece of legislation in the last Congress called the Mental Health and Language Access Act, which would enable folks who were working at community health centers to learn a second language in order to better serve the constituents that they are in the communities that they work for. And so, in my opinion, and I know in Senator Heinrich's opinion, we should be meeting folks where they're at, and if English isn't their first language and that's the only way that we're providing healthcare, then that's a disservice to those communities. So I would say, from my perspective, that's a really big barrier, and I think the COVID pandemic has really pushed us to start to resolve that and break down language barriers in healthcare. But I think there's still so much work that could be done. The other thing is really just getting people to the doctor's office and getting reliable preventative care. I think is a really important type of care that we should be focused on. And it's a barrier, particularly if folks don't have health insurance or if they are on and off Medicaid, if they are eligible. to getting that preventative care. I think this is a really big barrier because if they have access to the care, they can go to the doctor to get preventative care rather than showing up in the ER when something is much more escalated, and something that could have been solved with a primary care physician. So off the top of my head, those are the things that I think are some of the biggest barriers affecting the Hispanic and Latino communities, particularly based off of my experience in meeting with New Mexicans and also growing up in New Mexico.
Oh, no, thank you, Claire, for that perspective. During my time in the emergency department, that was one of the biggest problems. We were fortunate enough to have translation services, but not all hospitals and healthcare facilities have that luxury. And then, me speaking Spanish, I would have to physically write out the discharge instructions or even instructions for medication, because we had a lot of folks that would come to the hospital, get care, but they would have nobody to translate for them, or have that post, at home treatment or somebody to help them to really understand what they were going through. So language is so important. So thank you for that perspective. We're going to kick it over to Michelle. What challenges do health insurance providers face when trying to address social determinants of health, from your experience in AHIP?
Sure. Thanks so much, Cristo. I guess let me first start in kind of talking about social determinants of health
Yes.
and what different players are doing. So, for those who aren't familiar, I mean, this came out in the pandemic a lot, so many of you may be familiar, but social determinants of health or social drivers of health are those non-clinical, it's the living conditions in which people work, live, play, age. It could be, if you have grocery stores in your community that are easily accessible or that are able to offer healthy food options that are affordable and accessible. It could be having affordable housing. It could be having quality housing. It could be having transportation services. These all impact someone's ability to make healthy choices and to access quality health care. And so, a lot of my professional career, first with the community health centers and now with the health insurance providers, has been how can we better understand people's health related social needs, and then what can we do to better address them? So whether it's providing something at an individual level, so let's say you and I are having a conversation and you let me know that you've been living in a couple of different places, so you don't have stable housing. I can work with you and see if we can get you into some transitional housing or into some permanent supportive housing, because in order to be able to, let's say it's abide by some treatment plans that a doctor might give you, or to be able to take your medications, you first need to have a stable housing. That's going to be top of your mind if you don't have stable housing. So it's going to be hard to exercise or to eat healthy if you don't have access to a refrigerator, if you don't have access to safe places to walk or run or exercise. Same with food. If you don't have access to affordable, healthy foods, it's going to be hard to abide by, things your doctor might tell you to help manage your diabetes or your hypertension simply because of the circumstances that you're put in. So these non-clinical factors have a huge impact on our health outcomes and our health utilization patterns. And so what health insurance providers have been trying to do is to provide some of these benefits or services. So some of the examples are providing non-emergency medical transportation to access healthcare or to get to the grocery store, get to the library. They've been offering phones with data plans. I know we've mentioned, or Senator Heinrich mentioned, access to care and telehealth, especially for rural or frontier areas. So health plans have been providing phones with data plans or community resource centers that have free public Wi-Fi so that people could have their telehealth visits in private rooms, because especially during the pandemic when so much moved to virtual care, something that happened is if you're having, let's say it's a behavioral health conversation, sometimes many people didn't have a private place in their apartment or in their home to be able to have a private conversation with that. But community resource centers, they had private rooms. Each had a computer or a laptop but with a camera and a microphone so that people could have a private room to have their virtual care in a private setting with free public Wi-Fi. Health plans are providing medically tailored meals, or they during the pandemic they kind of switched to online grocery vouchers so people could order groceries online or having food delivered straight to them. They partnered with restaurants during the pandemic who were really hurting and were able to work with them to come up with medically regimented dietary meals so that it buoyed the restaurant industry, but then also provided, those medically tailored meals to their members. So they're really trying to come at it from a lot of different perspectives. But some of the challenges that they are facing is, and this could be some policy. So Claire, looking at you, in many cases, health plans are only allowed to offer these kind of benefits if and when somebody already has a chronic condition or a chronic illness, which means that it's helpful to help manage that chronic illness, but it doesn't help with prevention. And so we would really like to expand or facilitate health plans' ability to offer these services or benefits to those based on income, or based on if they're on Medicaid, or based on if they have like a food insecurity need or a housing insecurity need. That would really help with prevention. And another big challenge is because these are non-clinical services, they currently are not considered medical services when it comes to the medical loss ratio. And this is getting really wonky, so I hope people enjoy wonky conversations. But the medical loss ratio was a part of the Affordable Care Act, which essentially said that health insurance providers were required to spend 85% of the money they receive from premiums. So that's that monthly payment that you all are paying every month on your insurance plan. They have to put 85% of that towards medical services, which is wonderful. It makes sure that, the value of that dollar spent is going towards providing the care and the services. But unfortunately, with social drivers of health interventions, because they're considered non-clinical, they're not considered medical services. They're considered administrative. And so the health insurance providers are limited to what they can spend on it. So it really limits scale and sustainability. We would love if these could be considered medical services because they do improve outcomes and reduce costs. And that would give health insurance providers more flexibility to be able to do even more in this space. So thanks for that question, Christo.
Thank you so much, Michelle, for that response. Yeah, some of the social determinants of health are so hard to navigate, and in some cases, some people don't even know that they are experiencing a determinant. So it's important for people like us to, help identify those. I had an announcement from the back end before I ask a question to Bernie. If people in the audience could take a second to refresh their browser, apparently the Q&A chat box is having some issues. So if you just refresh your browser, we'll take maybe 20 seconds to do that, and then we'll hop into a question for Bernie. Will give us a couple seconds. Alrighty, and audience and anybody who has any questions, feel free to put them in the chat box, ask away, and we will get to them as soon as possible. Alrighty, kicking it over to Bernie. In your experience as a social worker, what are some common miscommunications people have about health inequities in the Latino community? And how can we better combat these miscommunications, these misconceptions? Like, what have you been seeing in your work in the community?
Well, I think what I see mostly in my work, because of the work that I do predominantly with overdose prevention education and distribution of naloxone to people who are at risk for an overdose, is stigma and discrimination. And stigma and discrimination directly impact health outcomes. And in the peer-reviewed literature, it shows that when any kind of health or social service provider, whether it is a social worker or a paramedic or a nurse in an ED or a medical provider, when they engage people with dignity and respect and treat people as individuals and look beyond, in my particular work environment, their substance use issue, and not just assign them as someone who is having an issue with substance, and look at them as a person holistically, that health outcomes are better. So part of my work is, unfortunately, and it's gotten worse actually over the last 20 years for me. Uh, Stigma and discrimination are continuing to really have a intense impact on health outcomes. Um, and over the last 3 years in New Mexico, again, in my particular line of work, we have seen an increase of 200 people per year since 2019 dying from drug overdose. And New Mexico now has an overdose death rate of 50.6 per 100,000. We are back in the top 10 at number 6 in overdose death. And stigma and discrimination and misconceptions about people who are maybe self-medicating because of lack of access to primary care and behavioral health are suffering. And just like there are social determinants of health, there are social determinants of problematic substance use. And one thing that I look at in particular in New Mexico is adverse childhood experiences and both personal and community trauma. Um, we have more than 30% of our children living in food insecure homes and living in poverty. And those two things are not even on the adverse childhood experiences scale. So I work very vociferously to humanize people and speak out when I need to um, make sure that people who are in health and social services are not fomenting the stigma and discrimination that we see at the broader level, and trying to rehumanize people and ensure that health and social service providers are treating people as individuals with dignity and respect, and not assigning them some sort of immutable essence, like they are, a drug addict, or whatever kind of pejorative language that people use, so that they see people as more than just the sum of their diagnosis, which often happens in health and social services, not just with substance use, but certainly in, as I mentioned earlier, in the last year, finding out that I have idiopathic osteoporosis, I have been medicalized and have been engaged as a diagnosis more than the whole person that I am.
No, thank you for that response, Bernie. And yeah, you're right. I mean, those stereotypes are so hard to overcome sometimes, and even from the healthcare perspective, I saw that in the hospital we had a lot of quote unquote frequent flyers that would always come to the hospital seeking help. And in my opinion, that was kind of a fault on our own, because we didn't want them to return to the hospital, right? So that means that there was some disconnect in the care that we were providing or follow up for the patient. And then it gives these negative stereotypes when it's really people coming to ask for help. It's a cry for help. So we have to do better about addressing those, and ensuring that we connect people with those resources. We have a question from the audience, and I'll kind of open it up to all of you, but we'll start with Michelle. This question comes from Karina. How is your organization working to provide preventative care and ongoing education around healthcare access?
Sure, great question. Thanks so much. Our members very much want to promote access to primary care, preventive care, so I guess taking a step back, AHIP, the America's Health Insurance Providers, we represent health insurance providers of all types, small, large, Medicaid, Medicare, commercial, small group, employer coverage, marketplace. So when I speak, in general, I do mean across all of our members in all of these markets and all of these spaces, but they do see the importance of prevention, primary care. And so for that reason, they often offer, no copays when you go for primary care. They have very low cost sharing on these preventive services like cancer screenings and whatnot. However, there's an interesting conversation happening around how to promote more high value care and reduce low value care. So, an example of this is high value care. So, your initial, once you reach eligibility, your initial breast cancer screening, that's covered. But then a situation might happen where if you are unfortunate enough to be diagnosed with breast cancer, oftentimes follow-up services are not covered and to the extent that they should be. And so there's having really interesting conversations around, okay, what can we as health insurance providers do to ensure that we are covering those high value care services that result from preventive or primary care services, and then reducing the lower value care services so that we're really supporting people and allowing them to make the healthy choices or having access to the care that they need at the time when they need it. So that's happening as well.
Thank you,
And I
Michelle.
guess I could also say like telehealth, that blossomed under the pandemic. And so that was another way to really try to, facilitate access to a lot of these preventive services, behavioral health being, a major one of those as well.
Of course, and I think that goes back to the overall literacy of insurance plans too. In my past job as a insurance specialist, a lot of people didn't even understand their own coverage or what preventative services are, how they were being billed. So a lot of people were missing out on sometimes free care that they didn't even know that they had. So yeah, that's super important to identify those. And throwing it back to Claire. To kind of piggybacking off of what Michelle said, have any of these barriers that we've discussed have they been addressed legislatively since the pandemic? How can we ensure patients stay out of the ED and have more access to their community resources?
Yeah, thanks so much, Cristo. I actually was going to say one thing that Michelle said that was making me think is that, my boss, Senator Heinrich, has introduced a piece of legislation called the Colorectal Cancer Detection Act, which would authorize all blood-based screening tests for colon cancer to have Medicare reimbursement. And part of the motivation behind that is colon cancer is so deadly, unfortunately. And to Michelle's point, like getting the screening is whatever screening it is the best screening for you. And making sure that health insurance plans and Medicare and Medicaid cover these screenings is a huge access point for people to getting care, because ultimately to get treated for a disease, you have to have a diagnostic test or some sort of diagnostic measure. So, in my head, and I know in conversations with the senator, really getting those tests authorized for reimbursement and ensuring that they're approved by the FDA is a really, really important point of access. And for example, blood based screening tests for colon cancer could just be included in annual blood work for people. So if they're already going to get their annual blood work, they can, get that added in, and they don't have to get an invasive colonoscopy, or if you live in rural New Mexico, like many of our constituents in New Mexico do, you don't have to drive to Albuquerque or El Paso or up to Denver and take time off of work and things like that. So I think in addition to just, getting these tests and diagnostic tools approved, like whatever screening you can get is the right one for you. And if that means a blood-based screening test as an initial test versus a colonoscopy, like that's really important. And to answer your question, Cristo, about, what sort of things have we really tackled since the start of the pandemic, particularly around barriers, I think the biggest one from a federal legislation perspective that we've tackled is telehealth access. CMS, the Center for Medicare and Medicaid Services, has expanded telehealth access for an additional 2 years. That was included in the omnibus that passed in December of 2022. That was a tool that really saved a lot of people during the pandemic, whether it was to access, general care without having to go into the hospital setting, or to access mental health services. My boss has also introduced legislation to make it so that clinical psychologists can be billed for Medicare. in order to improve access. So that's kind of the first thing that I feel like from a congressional standpoint that we've really accomplished. I think folks on both sides of the aisle really see the merits of telehealth, and how it's really a tool that should be utilized to help improve access to healthcare.
Yes, thank you, Claire, for that answer. Yeah, wonderful. I mean, telehealth is so important. The pandemic really taught us that. Oftentimes it's even diving deeper that people don't have access to internet, or people don't have cell phones. So it's really all those intersections of barriers to care, which is great. So yeah, thank you to the work of Senator Heinrich and other legislators such as yourself. Getting that work and identifying those barriers. That's really important. Throwing a question your way, Bernie. I know you kind of mentioned that you've had some personal experience already with your own, medical stuff. Can you tell us about a perspective that really changed you, or an experience that really changed your perspective or outlook on barriers affecting, Latinos or other people in the community?
So make sure I understand a personal experience that can be relatable, or
Yeah, a personal experience, or if you had worked with somebody that really changed your outlook, or you really identified a big barrier to health in your work.
well, I think the best example I could give is access to treatment for opioid use issues, and I've talked to Claire in your office about this, and that is access to methadone and buprenorphine for diagnosed opiate use disorder, and I use the example of if I live in Gallup, and when I want to be on methadone, there is no methadone clinic in Gallup. So in order to get, and methadone, for those of you who don't know, it requires direct observed therapy. So you have to get your methadone in a cup in front of the nurse and drink it. Unlike Suboxone or buprenorphine, which is able to be prescribed in a primary care setting. So if I live in Gallup and I want to be on methadone, I will have to drive to Albuquerque 7 days a week, round trip, which is about a 4-hour drive, 7 days a week to access my treatment for my opioid use issue. I cannot think of any other health condition that requires a 4-hour drive 7 days a week to get, for example, your insulin or your albuterol or your cardizem or any other medication. So to me, that certainly plays into, again, stigma and discrimination, because we require some, we don't have methadone access in rural and frontier areas in our state. And so for me, I can't imagine a 4-hour drive 7 days a week to get a medication. And so for me, that is one of the biggest issues that we see in our state, because um, we have 2.1 million people in our state, and we are the fifth largest landmass. So we have of the 50 states. So we have lots of rural. When we talk about rural and frontier, we really mean it. And so I think for me, the most profound issue has been um, someone who may not have transportation, or who has to, who may be on probation or parole, who may be trying to go to school or to work, and having to do that 4-hour drive a day to access a medication, to me is probably one of the most profound things I've seen in my work.
Oh, thank you, Bernie. Yeah, health access is so important, and distance, to your pharmacy plays a huge role in, your overall health outcome. We actually have another question for you that just came in. It says, Bernie, you hit the nail on the head with the focus on treating patients without stigma or discrimination. How can we intercede here? Is there a wide, sweeping retraining of those involved in healthcare and social service industries?
Good question, and that comes up a lot in my work. And I actually do stigma and discrimination training, and I do trainings on our use of language and how that informs our behaviors in our professional lives. I think what the answer to that question is it's not a one-time retraining. It is a ongoing retraining and engagement and supervision and individual work that needs to take place. We all have biases, and when I have been adjunct faculty at New Mexico Highlands University School of Social Work off and on over the last 20 years, and I have encouraged people that we have professional and personal biases. And when you're in your professional role, you need to remove your personal and professional biases to best serve the patient or the client that's in front of you. So it's not a one and done. It's ongoing, and it requires individual vigilance. We have to check ourselves. We have to evolve a critical consciousness within ourselves that allows us to be um, engaging our patients and clients with dignity and respect, and setting aside those biases when we are in our professional roles. And I think that health and social service providers should build this into ongoing training and provide CEUs and CMEs, and make this a part of an ongoing professional development, not just a one retraining kind of a thing.
Ooh, no, thank you, Bernie. Yeah, my experiences in past healthcare is we get trained, when we're first hired, and then no training, comes years and years later. So the evolution of training, that's a continual thing, and it has to be updated every now and then to hit all those, new barriers that are occurring. So thank you, Bernie. And we actually have a question for Michelle. You spoke very eloquently to the confluence of social determinants of the quality and available healthcare. What should the larger healthcare community be doing to address some of these factors that challenge access?
I love this question. Thank you so much for asking. And actually, before I jump to that, I just wanted to build on something Bernie was saying. I really appreciated what he had to say. Because when you talk about social drivers of health, so talking about lack of housing or struggling putting food on the table, those can be really difficult conversations to have. It could be traumatic for the person, it could be shame inducing for the person. And so when I was working with the community health centers, something that we did was using an empathic inquiry approach. And I'm sure Bernie's familiar with it. It might be called different things, but it's very much active listening. So repeating back what you hear, it's reinforcing someone's strengths in the situation. Because it does take a lot of strength to navigate these things or to do everything you can to overcome these barriers. And so I think that's something else that we've kind of learned when talking about these kinds of things, that using a very, letting them know that you're there, and just being supportive with this active listening and reinforcing someone's strengths really helps as well. But going back to the proposed question, something that really keeps me up at night when it comes to social drivers of health is that with the healthcare system getting involved, I mean, that there's trade-offs with that. I mean, yes, there's a lot more scope and resources that could be attributed with the healthcare system getting involved, but it is a very different system between healthcare and social care. And with healthcare getting involved, what's happening is we're focusing on social drivers of health on a very individual basis. So I'm sorry, my Teams is keeps popping up. So we are screening for individual needs. So Cristo, I would be engaging you in a conversation to learn about your housing needs, your food insecurity needs. And then we're focusing on, okay, well, what is a specific service or resource I can provide you to help address you with this individual need? That's good, and that needs to be done. But my concern is that we're not thinking more upstream, that by focusing on individual level, we're addressing the individual needs, but we're not addressing the root cause of the problem. And so I think something that the larger healthcare system or industry ecosystem could do is start thinking more upstream as to what these root causes are. So an example could be, we need more affordable housing writ large. We need a living wage, to help people be able to afford food or housing or whatnot. We need, to kind of Bernie's point, really think about these discriminatory policies that have been in place for generations and how that has had a trickle down effect on communities and has led to inequitable distribution of power and resources and money and investment in different communities. So that would be my suggestion, is that if we all have the same North Star around advancing equity, then we need to be working together and thinking upstream to address these root cause problems.
Thank you, Michelle. Yeah, oftentimes there's this, not enough time also when talking to patients. It's great to work at that individual level, but, it'd be nice if there was a solution to work at a larger level to hit more people at once rather than just seeing them one time in the clinic or in the emergency department. So that's so important. And, kicking it to Claire, legislatively, uh, like a lot of people haven't had the opportunity to work in government. People often just see the member, the senator, and they, don't really know about the work that people like you do in the office, and fellows like me do to support people like you and the senator. And building off of Michelle's point, what is like something that you would tell people that they don't know about your work, or how are you reaching out to those communities to address these barriers?
Yeah, I think to the second part of your question, I really rely on my colleagues that work for Senator Heinrich in the state. Um, we have 5 offices throughout our state in New Mexico, pretty much in every corner, or we of the 4 corners, and and also an office in Albuquerque. And I really rely upon those colleagues to help me keep a pulse on the issues locally, because they're on the ground, they're having conversations with local groups. Even though I'm taking meetings with constituents every day here in DC, I really rely upon their expertise and work on the ground to keep me informed about what is happening and how I need to better brief the senator, or how I need to think about shifting a recommendation to him just based off of what the dynamics are locally throughout the state. So I definitely really rely upon those colleagues of mine and of Christo's, because I'm not there as much as I'd love to be in New Mexico. I'm in DC in the Senate building, and what I'm seeing here is just not the same as what's going on in Las Cruces or what's going on in Santa Fe. I think, and to the first part of your question, I think there's a lot of misconceptions about the work in the Senate or in Congress generally. But I think the one thing that really comes to mind in this context is that in order to really make change and move the needle from a policy perspective, there are always compromises that lawmakers have to make to meet their goals. An example of this, which I'm using an example from one of my colleagues, but my boss has a piece of legislation about wildlife that he, almost got passed in the last Congress, didn't get passed, and he's been negotiating and making compromises with his Republican lead to get the bill introduced this Congress and to get it across the finish line. And it's like his signature piece of legislation. It's his real like passion project. And even though the way it looks now is not what he had initially hoped for, he was able to make a compromise with a Republican colleague to get that introduced and to now move it through the Senate. And so I think I take a lot of inspiration from that message, and from my boss's experience, that it's really important to come to the table and put your best bill out there, but really recognizing that in order to, unfortunately, in the political climate that we're in right now, we really do have to make compromises to make change, like that will really have an impact on people's lives.
Yeah, no, thank you, Claire. It's a great perspective. And I think the difficult part is that, people don't understand is that, every office is very specific and biased to their needs of their people. And, it's important to identify those needs and kind of, share with other offices like, hey, like we can work together on this because your people have similar needs. And, people don't see all those behind the scenes legwork to get, the co-sponsorship of legislation to get passed in every state, not just your own. So thank you for that question, or your response. And to one final question, I'm not sure who this is directed towards. Maybe whoever wants to, butt in. But hospitals, particularly safety nets, can be dinged for a high percentage of readmission. Some patients leave questions blank or do not list them on the forms if they have difficulty spelling them. And some have social determinants questions that are in the emergency medical records. So I guess to speak on that, what do we do to get, patients, to better fill out these responses or to track that data more so we can make change?
I can start. So when I worked with the health centers, I actually was part of the team that developed one of the first national standardized social determinants of health assessment tools that was built into the electronic medical record, or the EMR. And one thing we found was use a no wrong door approach when trying to gather this data, that it could be Christo, you in the waiting room while someone's waiting for their appointment. You could ask if they'd be willing to step to a private area and you can go through the questionnaire with them. It could be a nurse, as they're taking your vitals, can ask some of these, social determinant questions. Sometimes providers want to ask some of these. Sometimes they don't. In many cases, they don't, but they do want that information at point of care to know that, oh, maybe I shouldn't be prescribing this medication to you because you don't have a refrigerator access. So I think part of it is, again, not viewing it as like a form to fill out or a survey that they have to fill out, but use it as a point of connection and to build relationships with people. And also, if it's not someone filling out a form, but it's more a conversation, then that also provides an opportunity to share with the individual. So it seems that you would like to work on these things. Here are some resources that are available to help you with these if you are interested. Whereas if someone fills out a form and there's no follow-up, then that's very disrespectful to the individual. You're asking for very personal, sensitive information, and then you're not doing anything with it. So I think we need to make sure that this information is very action oriented. But I think something else that might help is having something that explains at the beginning, like why this organization or this entity is collecting this information, how it will be used, how it will not be used, who it will be shared with as part of the care team, and how it's going to be protected. I think that's critically important if we're going to be asking people more information about how they identify. That's a big space with like sexual orientation and gender. Asking things about their living circumstances. Again, these are very personal questions, so I think that needs to be at the forefront. And something else, we need to start reframing the value conversation. So the point about how some safety net hospitals will get dinged if they have readmission rates above 30%. Of course, we want to have more primary care access and encourage people to use primary care. But in some cases, people need to go to the hospital. And so they shouldn't feel bad or be penalized for using the hospital if that's the type of care that they need. And so I do think conversations need to be had about reconsidering what measures we are using to apply to hospitals, to plans, to providers, and ensuring that it is promoting services and coverage that helps people either, get care or services in their home or community, but then also facilitating access to the care that they need. And in some cases, they might need a hospital. So I do think that's an important conversation that needs to be had. And I'll be curious what Bernie or Claire have to say too.
Yes, thank you. And a point I just wanted to bring up is, that there's a lack of, trust in the healthcare system to, especially amongst Latinos and other people of color, specifically for that reason. It's like, what are they going to do with that information, right? Especially if you don't have a social, or you're undocumented, or you have other family members that are. So we got to work on, building that, more trust in the health system that we are trying to promote, change. And Bernie and Claire, did you have anything to add?
Yeah, I'll just quickly say I totally resonate with what you're saying, Michelle, but I think unfortunately in because of how our healthcare system is set up, um, people go to the emergency room for care, and if they can't pay or don't have insurance, they're often turned away. And so if it was better, I feel like it would be better for our healthcare system to say, hey, you're coming here for, because you have an ear infection. Let me direct you to our urgent care center, which like seems like such a simple change that just doesn't happen, but really disenfranchises people from accessing the care to begin with. And, if they're not insured or underinsured or don't know how to navigate the health care that they have, going to the emergency room certainly can be the first line of defense, but um, I think there's more that we can do as a society and as from a government perspective to ensure that people have other means of accessing care than just going to the emergency department. And that's obviously not what you're saying, but I think it should be seen as more of a last resort, and the emergency room should be helping people to access the care even if it's not right there in their emergency department. So that's just one thing I'd add. And I think unfortunately the way that we've structured our healthcare system in the US has really made it challenging for folks to sort of get that message that at the end of the day, like healthcare providers want to give care to people, and you show up at the wrong place, that's okay, but we will still make sure that you get the care that you need.
Yes. No, thank you for that response. Yeah, one thing that exactly happened to my hospital, the ED was getting so overwhelmed that they created a urgent intake center, determining whether if your problem was big enough to actually go to the emergency department. So is that problem exactly that patients use it as a first resort rather than a last resort, but we need to fill in that gap of actually um, giving them resources to go somewhere else rather than coming back to the ED. And Bernie, any comments or?
I would only add the reinforcement of the no wrong door um, in all of our health and social service providers in our communities.
Gotcha.
We get boxed in and we get siloed in, and that's particularly difficult for marginalized people who are facing lots of challenges and comorbidities and not only in their health but also in their living situations.
Gotcha. No, thank you. And we are getting closer to wrapping up, so we'll go around and we'll do a call to action. Maybe one thing you want people to take away from this conversation, and where should we go from now? Maybe we'll start with you, Claire.
Yeah, one thing that I hope that the audience takes away from the panel is, you know, there's a lot of really positive progress that's been made for folks in accessing healthcare throughout the US, but there's still a lot of work to be done. And whether that is through federal or state legislation or through working on a state level with departments of health or with health insurance plans, like there's still a lot more to be done. And I think we're making progress in the right direction. But I look forward to working with people across the aisle from organizations across the country and in New Mexico to continue to make that change. And just really grateful to be a part of this discussion.
Thank you, Claire. Bernie.
Well, my recommendations would be very specific to what I do for a living and the people that I work with and for. And that would be to have treatment on demand, drug treatment, alcohol treatment on demand, treatment instead of incarceration. It would be to increase access to sophisticated drug checking for people who are using street drugs in our state. And lastly, it would be for the decriminalization of drugs. It is the unregulated street drug market that is driving illicitly manufactured fentanyl overdoses in our state. And so that is very specific, but that is in my wheelhouse. And that's not something that I haven't said to the senator's staff already. So I would just end with thanks for having me, Christo. Good to see you again, Claire, and good to be on the panel with you, Michelle.
Thank you, Bernie. Michelle?
I would just say don't underestimate the value and the power of your voice. As Claire mentioned before, you know, your local representative offices are open. They are eager to hear from you. I think healthcare organizations, you know, our work will be better when we learn more from what is working well and what is not working well on the ground. And so just use your voice. We all come with strengths. And so by, you know, learning from each other and valuing each other's strengths, you know, that's how we're going to be able to move forward and move forward better. So just use your voice. We all would like to hear it.
No, thank you. Your voice is so important. And that was kind of my, thought process in throwing together this panel. I wanted to take somebody in the government, somebody in the insurance, and somebody in the community working on the work, and then my background from healthcare to all come together, talk about these barriers, and moving forward, looking how we could work together to really tackle these issues and promote change. So there's still more work to do, but we're getting there slowly but surely. So thank you so much, Claire, Michelle, and Bernie, and everyone who joined from the audience, who gave questions and took time throughout their days to be with us. So thank you so much. And at this time, the panel is over.